Doctor, whom this OncoRx test is actually meant for, and which all patients should go for it?
Yes, this OncoRx test, it is designed in a way, and even the FDA approval is to get this test, especially in stage 3 and stage 4 solid tumor. And having solid tumor meaning any tissue which is being biopsied, not the hematological malignancies. So, what we do in OncoRx test is we do three things. One, we take the solid tumor tissue, we identify what is the cancer in that sample, we isolate the DNA from it, and we do DNA sequencing at a depth of 1000x, which means we expand the DNA through PCR technology to expand it to 1000 times, and then we sequence it. And this is the gold standard testing for any companion diagnostic globally. And once we do the testing, we use MSKCC, which is Memorial Sloan Kettering Cancer Institute software, to interpret this data. We just don't leave it there because we want to confirm, because all these targeted treatments are really expensive. We need to really use it for the person who qualifies for it. So what we do in the next stage is, from this tumor sample, at the same time we also isolate the RNA. So we make sure that whatever the mutations that we are seeing at the DNA level are translating into the RNA level. So we do sequencing of the RNA to see if the tumor is expressed. That way we can also make sure that there are fusions available. So most of the targeted therapies either target the chimeric protein, which is coming from the RNA. So we can be almost confirmatory level, we can assure that there is this mutation which is causing this cancer, and this medicine will work in this patient. At the same time, the third thing we do is we confirm something called microsatellite instability. We do a Sanger sequencing for the test, and then we say, okay, this microsatellite instability is there in this patient, for which there is a specific drug which is for curative intent. I'm not talking about going to remission. So the chances of having this MSI instability is about 3 to 4%. But if you have it, then this drug will cure the cancer. So we do level testing. One is DNA sequencing and the analytics, and then the RNA sequencing and the analytics, and then MSI. Not only this one, we are also trying to gather a longitudinal data of these patients. So we just don't do sequencing and give the report. We work with partnership with the oncologist to gather what kind of treatment worked on this patient, when was the remission, what were the side effects of the medication, so that we create a data set which will be very useful to predict the outcomes of each and every medications. And if the targeted treatment is given, did it work, did it not work, and in that case, why did it not work, so that we can do analysis going forward. So I would recommend the oncologist to consider this test. So the most common feedback I get is there is only 10% chance, or there is only 5% chance of finding a targetable mutation. Why should I do this test at this expense? So from my side, unless we gather the data, how can we be sure that what kind of mutations? So once we have this data, for example, after 1 year down the road, the patient is there, and then there is a new drug which is being approved recently. So we can look back and see, does this patient is harboring that mutation? Does she qualify for this new medication? We can always close the loop by calling the patient, okay, when we treated you, this drug was not available, now it is approved and you qualify to get it. So these kind of data set we need to build, and we are open to participate with oncologists to create this database. And also one important point that we are finding out is there are multiple mutations from our data set, from the sequencing we did, which are novel. Novel meaning they are not documented in any database. So the question comes in, is it very common in our population? What does this mutation mean? And these are the things that we want to publish in partnership with hospitals and oncologists, so that the research will start moving forward to see if there are any new driver mutations which are causing cancers in our population.